Hello everyone and welcome. Today we're here on the second to the last day of CROI in sunny Seattle, or not so sunny Seattle. And I'm here today with doctors Kristine Erlandson from the University of Colorado, Denver, and Dr. Alan Landay from Rush in Chicago. So welcome, thank you for coming.
Thank you.
Thank you.
And today we're going to be talking about HIV and aging, which is a topic that every year gets bigger and bigger as we continue to get older and older collectively. So, but there are a lot of exciting things happening. So what stood out for you this year at the conference that you think is kind of new and exciting?
I think one of the most well-attended topics that I was at was the one today on the integrase inhibitors and weight gain. A lot of interest in potential side effects of these first-line therapies and how that might impact people as they age.
Right.
What sort of interventions do we need to curb some of that weight gain, and do we actually understand why people are gaining weight?
It's kind of like lipodystrophy has returned, right?
That was part of the question is this a generalized weight gain, or is it something that's more specific, or is it something new that we haven't seen before? So is it lipodystrophy returned, or is it something completely different? So.
And I really enjoyed the plenary talk by Dr. Irene Seretti, which really put the whole field of inflammation back in our topic of interest, and I think refocusing us around comorbidities, outcomes, and trying to understand, what are the specific pathways? Are there common pathways for cardiovascular disease, bone osteoporosis, neurocognitive outcome, metabolic or diabetes, or even cancer in our patients? And I think we really need, and have used the analogy that was shown by Dr. Seretti that Peter Hunt at UCSF originally came up, the tree analogy and all the branches, and how do we look at the trunk and the leaves, and it's a very complicated tree.
Yeah.
But if we can understand that the root, then we can develop interventions that are going to impact all of those branches and not just one.
Right,
Yeah.
and I think it really brings back, because HIV is still there, and I think we're beginning to think more about what is the role of HIV in the persistent inflammatory responses, but also other co-pathogens. CMV is getting a lot more interest, and we're now moving forward in that with some newer...
There's a CMV vaccine in the works, right?
There is, and there is a new vaccine that we'll be able to utilize in the ACTG as a trial coming up in the next year, and that protocol is moving forward. And there's also a drug that was licensed for transplantation from letermovir. It's a new CMV drug, and I'm sure Kristine can tell us more about how that...
The transplant population.
Yes,
Yeah.
If you actually
a much safer option than some of our old CMV treatments, so it'll be interesting to see if that's a more viable solution compared to some of the older drugs that you wouldn't want to have to take if you didn't have to.
Right, because I remember being myself on ganciclovir, and then ganciclovir back in the day, and the neutropenia that it caused. But they were prophylaxing against CMV blindness, so it was worth it.
Definitely worth it at that time. But if you don't have a clear benefit, it's a little harder to see that risk-benefit relationship. So.
And you were talking about metabolic syndrome, and certainly metformin is a drug that's been used for that for a long time, and there's been kind of waxing and waning interest in that over the years, and it seems to be waxing once again.
Yeah, no, I think there are a couple posters and presentations here, and more interest in reviving that drug, and it's also, they're starting a big trial in the aging world, so there will be a lot of parallel interest of metformin now from both the HIV community and the aging community. I think, as we've talked many times over the years at this session, Jeff, that we really need to break down any barriers that exist between the HIV infectious disease and the gerontology world, and thinking about new concepts of geroscience and other therapeutics that we can begin to look across the aisle, and using some of the simple measures that are there, like the short performance battery measurements, walk speed, and chair stands and grip strength, which are all fairly simple measures that do have impact on predicting patient morbidity and mortality. And I'm sure, as Kristine can tell you more about other simpler interventions that can be used as well.
And I think, as Alan mentioned, one of the kind of refocusing our endpoint, we've been very focused on inflammatory markers, but those don't necessarily mean anything to the patient. And when we can demonstrate that a drug at one of these interventions can actually improve someone's physical function, it's a much more meaningful outcome. And I think it gives a lot more reason for the patient to see why there's a benefit in the drug. If they have a decrease in one lab marker, it's hard hard to convince you to take a drug for years on end if you don't see the immediate benefit.
Well, and to get an insurer to pay for that drug.
Exactly.
Yeah,
yeah, just by a biomarker, it's
Right.
a little harder. And as Alan was mentioning, trying to bridge these gerontology and HIV fields, and there's some exciting data coming out in the gerontology field on some of these senolytic drugs that may
Right.
slow the aging process. And if we can focus those on some of these meaningful patient outcomes, like can we actually improve physical function, I think that's huge.
Can you tell us more about the senolytics, what they are and how they work? And
That's probably more of Alan's field. I think from my standpoint, there was just one of the first senolytic drugs that was approved that was tested in human use that showed an improvement in physical function, which
Right.
is amazing. And they actually didn't find an improvement in a lot of these inflammatory markers, and instead found an improvement in simple things like how fast can you walk up from a chair, stand up from a chair, and how fast can you walk. So I think that the potential for these drugs is great if you can find a drug that's tolerable and safe.
Yeah.
I think from that standpoint, there's a lot of appeal for metformin because it's generic, it's really quite safe,
Right.
and it's quite tolerable, and so that's a very appealing option there. But I'll let Alan talk a little bit more about the potential mechanisms of the
Yeah,
senolytics.
so the senolytics means that as you age, your cells become resistant to dying, and so they become, it's called a process of apoptosis or cell death. And so now we know that those cells turn on apoptotic mechanisms, so they survive. And what they also do, they develop what's called a senescent associated secretory phenotype. So a new acronym for the audience is
Say that
SASP.
3 times fast.
Yeah, say that fast.
Okay.
SASP, the SASP. And so this is very critical because it's those inflammatory mediators that persist, and once they're there, they can drive all the diseases of aging and comorbidity. So we're now trying to think about how to target those in aging. As Kristine said, the first of those studies was done in pulmonary fibrosis disease, which is pretty much a disease in which you die from in 4 months. And so the actual drug that was used is from the cancer field. So it's used to treat leukemias in cancer, and now adapted from a screen into the aging field. But interestingly enough, that same drug, which has effects in cancer and aging, is also being used to drive out latent HIV. So now it also has activity as a potential cure strategy. So we're really looking at tremendous intersections of all these fields together to really drive the science, but also have multi-utility. And I think that's going to be very exciting times as we think about our aging population, the added benefits about adding in a senolytic drug that not only can affect your performance and physical outcome, but may also have an additional value for latency reversal.
But while these drugs are in process, I think it's really important to come back to what we do know can prevent aging, which are things like lifestyle, healthy lifestyle, and most importantly, trying to stay physically active as people get older, and then trying to keep a healthy diet. I think our opinions of what's healthy and ideal for diet continue to change, but we know some basics, and trying to avoid high salt and healthy fats like fish and kind of that Mediterranean diet as much as possible, avoiding smoking and avoiding alcohol. And I think those will always be kind of the cornerstone of how we can slow the aging process and keep people healthy. And then these drugs are just potentially added benefit or options in people that can't, for some reason, exercise if they have physical limitations, or add to that.
And that's absolutely true. And the diet itself has an impact on your microbiome, which is very critical. That's the whole host of bacteria, viruses, and fungi that live within us. And as we know, the fun fact is that we're more bacterial and microbiome than we are host cells at an almost 10-to-1 ratio. So these are fun facts for your next cocktail party that you can amuse your friends about. And actually, when we're sitting on our seats, we're actually depositing some of our microbiome directly on our seat, which I know gets a little scary. So there's a lot of very fascinating new work in the microbiome and how some of the actual function of the microbiome. And we now have in our field of microbiome studies in HIV and aging, we're talking about not who's there, but what are they doing, and how can they now, through their metabolite production, affect outcomes. So we're learning so much new science, and a lot of it we can manipulate, as we talked about. Diet is going to be a critical part of this outcome. And some of the things in aging that are even more interesting is looking at the gut-brain axis. we're starting studies in our own institution in Chicago with what is called the MIND diet to try to reduce the decrease in cognitive function in aging. So,
Can you tell us more about that?
So this is a combination of what's the healthy diets of the Mediterranean diet and a DASH diet together. And
what's the DASH diet?
The DASH diet has it has a lot of berries and other
and low sodium.
Low sodium,
Okay.
yeah. So it's all the good things that that Kristine just told us about that you should be eating, and then we're going to study the microbiome as part of that to show what happens and also have the clinical outcomes in neurocognitive aging.
Well, certainly diet. I mean, you talk about both probiotics and which is the diet which you put in what the critters feed on, right? And then there's those are the prebiotics, and then probiotics. And I know there was a study that was reported, an ACTG trial that reported on that didn't show anything, really marked benefit from that.
No, and I think that's kind of the question right now is what's the ideal population that we should be targeting, and are we trying to intervene on too healthy of groups that we're seeing a population that has fairly well-controlled HIV and they're fairly healthy, and maybe we should be picking out more frail patients or patients with neurocognitive impairment when we're trying to intervene with some of these mechanisms.
Right, so you can actually see a difference.
So we can see a difference, yeah. And maybe there's more there that we're just missing by our fairly small sample sizes on these interventions. But if we target a population that has more pathology or more that's actually inflamed or more physical function or cognitive impairments, maybe we'd see greater benefit. So that was some of the discussion in that session is, are we picking the right patient population to test our interventions on?
Right. And then, if you do use the probiotics, are the bugs themselves going to be effective, or do you need to change everything, about the host, right? So you have a better diet,
Like Alan said, it's some of the function, not just the bugs that are there, but what are they doing? So we can pour in good bacteria and replenish that, but if we're not feeding them fiber and not feeding them some of the substrate they need, then we may not make much of a difference on the actual function and what they're producing.
Right. So you have to create the right environment. It's the same thing we've heard about here in our new cure patient from London in terms of creating the environment in the bone marrow when we transplant. We also, when we give the probiotic, we have to actually create the right environment. So maybe the environment is hostile to this, what we're giving in terms of the probiotics, and if we don't change the essential areas and environment, we won't have an effect of our probiotics.
And then like plants, we have to give those bacteria the right food and the right nourishment to actually let them do their job. They may be there, but if we can't nourish them in the right way, then they may not do it the effect that we would like. So.
Just like us, they are with what we eat, right?
Exactly. Yeah.
So you touched on diet and exercise. Is there anything exciting going on in terms of research around that has been reported or is being planned?
We presented a study from our site in Colorado last year at CROI, where we looked at a high intensity versus a moderate intensity of exercise on physical function, and found that both those with HIV and those without had very similar improvements in physical function, and actually saw that in some outcomes, those with HIV had better improvements in their strength when they were randomized to high intensity. We have a follow-up from that here where we're looking at muscle mitochondrial function in our exercisers, and we saw that despite those improvements in both the exercise, those with HIV and without HIV, the group with HIV seemed to not change their mitochondrial content quite as much. And so I think that asks, are there added things that should be done? Should we change the type of exercise, or do we need to add different fuel to those with HIV when they're exercising to try to boost their mitochondrial content a bit more?
Right.
We didn't collect function, so we can't say whether or not those mitochondria aren't functioning quite as well. But I think I didn't see a whole lot else on exercise here this year. That was the one study I saw. And I don't think I saw a lot on diet. In the adult population, there may have been a bit more. I think there were some supplements. I saw a zinc poster, some other kind of supplements to try to change inflammation. But I think physical activity is really important to preserve function. It's one of the only things we see that improves physical function as people get older. So I would like to see more on how much exercise, what type of exercise, what do people stick with, and how do we get people to keep exercising, which I think is the key, is we can show it works, but if people don't do it, it doesn't work in real life. So I think
just like quitting smoking, right?
Exactly, yeah.
It works if you do it, but it doesn't if you don't.
Yes, exactly.
And there's actually a metabolic product called NAD, nicotinamide adenine dinucleotide, that's very critical for mitochondrial function. And we know during both aging and HIV that particular metabolite is reduced. And so there may be, again, ways in which we're now looking potentially to replenish that and can actually get back those levels. And that may also be an added value, as was talked about by Kristine, that if we add and bring back some of those functional metabolites that the muscle needs in the mitochondria, along with exercise, that may also be what we're going to have to do to really improve the physical function.
So another kind of combination therapy once again.
Yeah, a cocktail of the best ways to improve your muscle.
Ones that you don't get at the health food store now, right? Open any magazine, you'll see all kinds. But, so speaking of kind of future research, I know that the AIDS Clinical Trials Group has recently formed a new HIV and aging working group, of which you are the head, along with Scott Latender. Can you speak a little more about that, what it's about and what they plan to do?
Yeah, I think we have a couple purposes. One is to get use some of the existing samples that we've collected in the ACTG over the last 30 years, and try to go back and look at some questions on aging. Can we use some of the existing samples from studies of metformin, for example, to see some of the immune changes and what we can learn to inform future studies? The other point is to try to use some of our HALO cohort. Our HALO cohort is a cohort of older, or 40 individuals 40 and older with well-controlled HIV that have been in the ACTG as a follow-up to the ALERT cohort. And that cohort has very valuable data, and so really trying to get new investigators to ask new questions and try to use some of that data. And then I think the other point that we're trying to, or the other goal of the working group is to try to generate new ideas for new interventions. Things like the senolytics, can we get more metformin? Are there exercise interventions? Other things that we can test in the ACTG that focus on the aging questions. And as a pair to the HIV aging focus group, working group, there's also the community working group focused on HIV and aging and trying to come up with key topics that the community feels are important, and how can we as the scientific working group try to address some of those key questions.
Yeah, the ACTG has always had a very robust community advisory board, and every few years they put together a list of the community priorities. They actually survey people, and we're trying to replicate that process there for just around aging to see what the priorities are there.
And how can we, as the scientific working group, try to address those priorities within the expectations of the trial and kind of our funding sources, and trying to meet all of those key goals that everyone has, and best move the aging agenda forward within the ACTG.
Yeah, that's very exciting to see, because I know over the years, the ACTG has always been in the forefront of developing, addressing problems as they emerge. Hepatitis C, lipodystrophy back in the day, and now they're doing the same with aging.
Yeah.
So it's encouraging to see. Terrific. Well, did you have anything else about the conference or the field in general that you'd like to talk about?
I think it's exciting this year to see focus on comorbidities. I think within the years past, it's been a really heavy focus on cardiovascular disease, and I'm excited to see that it's branched out a bit more. We're looking at some other neurocognitive impairments and just some other comorbidities that have come out this year. It's always interesting to see how all of the posters kind of go one direction. Lots of interest on fat and body changes this year, and just kind of which direction it'll go in the years to come. But it's nice to see lots of interest in comorbidities and in research that's advancing the field, I hope. So.
Well, absolutely. I mean, people are otherwise doing pretty well with HIV. We have pretty good drugs these days, and people have access to them. They do pretty well, but these nagging issues of aging as we get older and the comorbidities that you talked about, I think, continue to be
and I
a
think
problem.
One of the things we recognize in talking to my colleagues is this is really a global issue. This is not something that just the developed world, it's also the developing resource limited settings. So as we come to a meeting like CROI, which is truly international, and we look at what's going on in places in Africa and South America or over the globe, we really recognize that many of these diseases of aging are also impacting the patients in those parts of the world. And so we really need to think about how these comorbidities fit not only with HIV, but other critical co-infections. Tuberculosis, for instance, is another important driver, and one of the areas I know that's being looked at is the role of TB and diabetes, which is an important driver. And so this whole idea that infectious agents can drive metabolic outcomes is very interesting, and one where I think we'll have a lot to learn, and how to then deal with these very basic infections in the developing world and also deal with the attendant development of the comorbidities with them.
Absolutely. Well, terrific. Thank you so much for joining us
thank
today.
you.
Look forward to seeing you at next year's CROI.
Thank you. Thanks again.